Good afternoon, everyone. PCOE Sion Hospital welcomes all the participants for today's RDLS session. Today's topic is immunization among CLHIV, and the speaker is Dr. Yashwant Gabhale. Dr. Yashwant Gabhale, sir, is the additional professor with the Department of Pediatrics and the program director of the Pediatric Center of Excellence at LTMGH and LTMMC, Sion, Mumbai. He is also the in charge of Nutrition Rehabilitation Research and Training Center. His areas of interest include pediatric nutrition, pediatric HIV, and pediatric asthma. We welcome you, sir, for today's session and request you to start the session.
या धन्यवाद मिस श्वेता. सर्वांना मराठी भाषा दिनाच्या हार्दिक शुभेच्छा. त्याच्यापासून मी सुरुवात करतो आणि आपलं रिजनल डिस्टन्स लर्निंग आहे, थोडं मराठी पण बोलू आणि हिंदी पण बोलूया आपण. तर इम्युनायझेशन इन CLHIV हा फार इम्पॉर्टंट आणि जिव्हाळ्याचा टॉपिक आहे. जसं तुम्हाला सर्वांना माहिती आहे की लहान मुलांची कवच कुंडली आहे. इट्स लाईक अ प्रोटेक्टिव्ह एन्व्हायरमेंट. वाय वी गेट इम्युनायझेशन. तुम्ही सगळ्यांनी कोविडमध्ये अनुभवला होता की तेव्हा कोविड जेव्हा होता तर देर वॉज अ नीड टू डेव्हलप अ वॅक्सिन अँड द वॅक्सिन वेन इट वॉज इन द मार्केट everybody took the vaccine to protect themselves. Therefore, immunization is very, very important for all the CLHIVs, especially in children, because लहान मुलांना माहित आहे की they are prone for infection, they have low immunity. So therefore, there is a need to protect these vulnerable children. So here we will be discussing something about त्यांची immunity काय असते, what are the types of vaccines, killed आहे, live vaccine आहे, live attenuated vaccines आहे, त्याचा इम्पॅक्ट काय असतो, आणि व्हॉट इज द एपिडेमिओलॉजी, म्हणजे ओव्हरऑल सर्व्हेलन्स काय सांगतो, वॅक्सिन्स किती सेफ आहे मुलांना देणे, एस्पेशली इन टर्म्स ऑफ HIV इन्फेक्टेड. नॉर्मल हेल्दी मुलांना आपण सगळे वॅक्सिन देतोच, but there are some vaccines which we are worried when we are giving to HIV infected children. Then all vaccines comes with the adverse events. So it is true for HIV children also. So how to tackle this adverse event and which are the adverse events which can occur with particular vaccines, and what is the vaccination schedule of HIV infected children, that whatever we follow for a normal child, that all we follow for HIV except with some vaccination which are not given in HIV infected children. So immunization, it is a tool to control eradication. It is always taught to us in preventive and social medicine that prevention is better than cure. So मग एखादा आजार होऊच नाहीये त्याच्याकरता काय करायचं, त्याच्याकरता आपल्याला वॅक्सिनेशन अवेलेबल असतं. So these vaccines are available now free of cost across the nation. Initially there was some vaccines which were available only for 6 diseases, and later on it has over a period of time this vaccination, more and more vaccines were added in the national immunization program. सो हे जे माइलस्टोन्स आहेत तुम्ही याच्यामध्ये बघताय की 1985 ला जेव्हा वॅक्सिनेशन लॉन्च झालं, युनिव्हर्सल इम्युनायझेशन प्रोग्राम, गव्हर्नमेंट ऑफ इंडिया सेड इम्युनाइज ऑल चिल्ड्रन. ओके, ऑल चिल्ड्रन लेस दॅन 5 years सगळ्यांना वॅक्सिनेशन भेटलं पाहिजे. त्याच्यामध्ये ठराविक वॅक्सिन्स वेळ अवेलेबल होते, पण जसं इनपुट्स भेटत गेले सरकारला आणि त्यांना कळायला लागले की काही काही वॅक्सिन्स they need to be added. So hepatitis B became a part of the national immunization program 2001. And नंतर मग मिझल्स पण ऍड करायला लागले, MMR नंतर ऍड केलं, जेई जिथे जिथे एंडेमिक एरियाज होते तिथे जेई वॅक्सिन्स त्यांच्याकडे अवेलेबल केले गेले. असं करता करता मिशन इंद्रधनुष्य लॉन्च इन 2014, आणि मग स्पेशल ड्राईव्ह चालू केली गेली की वॅक्सिनेट ऑल चिल्ड्रन. आणि इट वॉज ऑल्सो डिसाइडेड दॅट vaccinate all the pregnant women also along with the children by 2020. So this is milestones that now all the vaccines are available and all the government setups. So why to vaccinate CLHIVs? As you are aware, these children are having low immunity, and because of the low immunity they are susceptible to more diseases. So once you vaccinate, what vaccine does, it induces the immunity against that particular diseases. आणि त्याच्यामुळे काय होतं, त्यांना एखादा समजा आजार व्हायचा असेल तो पटकन बळावत नाही, लवकर मोठा होत नाही, किंवा त्या रोगाची रोकथाम करण्याची शक्ती त्या मुलामध्ये येते. So that child can at least prevent the disease before it is getting early disseminated in the body. जसं आपण लहान मुलांना बीसीजी लावतो, तर बीसीजी लावल्यामुळे काय होतं, ऍटलीस्ट द चाइल्ड इज प्रोटेक्टेड फॉर डिसेमिनेटेड टीबी. त्याला टीबी होण्याची शक्यता नाकारता येत नाही. ओव्हर अ पिरियड ऑफ टाइम यू कॅन डेव्हलप टीबी डिपेंडिंग अपॉन त्याच्या आजूबाजूला कसं एन्व्हायरमेंट आहे. जर इफ इज सराउंडेड बाय ऑल द टीबी पेशंट, is living in a very unhealthy environment, he will definitely get a TB instead of he is vaccinated with the BCG vaccine. But this is not true for all other hundreds. 100 मधले फक्त 20-25 जणांना समजा TB होईल, पण बाकीचे ऍटलीस्ट प्रोटेक्टेड राहील 75%. So that we are aiming. So at least we have to give vaccination to all the children so that others are also protected. As you are aware, HIV is a disease which causes decrease in the immunity and which can further lead to lower immunity. जसे त्यांची immunity down होणार, they are susceptible to more and more diseases, and there are so many diseases are there. But at least those vaccines which are there, which are safer to be given, should be given to all these HIV infected children. And therefore, counselor, I always say the counselor plays a very important role. Whenever the counselor sees any child, you should also look the immunization history आणि त्याने immunization record check केलं पाहिजे. आणि त्याच्यात काही समजा missing असेल, so it should be immediately noted and informed to the medical officer. Of course, medical officer is going to check the immunization status of the child, but still counselor also plays a very important role. आता immunity बघायला गेलं, there are two types of immunity. One is the innate immunity, which is comprised of the skin, mucosal barriers, and the phagocytes in the body. And second is the adaptive immunity, which is provided by our lymphocytes, which are basically T and B lymphocytes. So this both the immunity plays very important role. The innate immunity system triggers the development of the adaptive immunity by representing the antigens to the B and T lymphocytes. And therefore, this vaccine are going to stimulate the innate immunity, and therefore it is having a better immunity response. आता दोन प्रकारचे immunities असतात. One is the active immunity, second is the passive immunity. So what do you mean by active immunity? So active immunity is the one where you are exposed to a pathogen in the environment and your body reacts to that. So what you have seen in the COVID era also, in COVID era, what some patient, some people got infected with the COVID virus and they got developed a natural immunity and they were having good immunity power. So that was a natural this thing. And second is the artificial. The artificial is always by a vaccination, where the vaccines are injected in the person's body and where the person can react to the whatever antigen are introduced in his body by producing the antibody against that virus or against that species. Then coming to the passive immunity. Passive immunity is the one where mother transmits her antibodies, which can be by the transplacental or by the breast milk. So these are the maternal antibodies. Second is by blood products. So which are the blood products where we are specifically having a monoclonal antibody in certain diseases, where this can be given. Especially in cancer, we can give this monoclonal antibodies. So this is a passive immunity type. So active versus passive immunity, there are specific different immunities exist. As I said, active immunity is following a clinical infection, following a subclinical infection. So this is a natural type. And passive immunity मध्ये पण जेव्हा मदर कडून बाळाकडे जातं, either through placenta or through the breast milk, it is again a natural type of immunity, but it is a passive immunity. Then acquired one is following vaccination, which is the active immunity. And following administration of the immunoglobulin or anti-serum is a type of passive or acquired type of immunity given to a patient or a child. So this is all interrelated vaccines. Like we have immunizing agents, which are like vaccines, anti-sera, and immunoglobulins. So these are going to protect the child. So vaccination, it is a method of giving antigen where the antigen is injected in the child's body and which stimulates the immune response to the active immunization. And a vaccine is an immunobiological substance which is in turn is designed to produce a specific protection against the given diseases. So like this, we have various vaccines. So some are live attendant vaccines such as polio, BCG, MR, measles, mumps, rubella, that is MMR vaccine. Then there are some killed vaccines which are maybe inactivated toxin or toxins or organism subunits are there, then there are wholesale inactivated in that category, like rabies, IP, inactivated polio, that is IPV injectable, hepatitis A. Then we have toxoids against diphtheria and tetanus. Then we have subunit vaccines, which contain only the antigen parts of the virus or the bacteria. Then protein vaccines in that category is the acellular pertussis, like hepatitis B or some influenza viruses vaccines are there. There are some pure polysaccharide vaccines such as typhoid, then meningococcal polysaccharide vaccines are there. Then there are some conjugated polysaccharide vaccines such as typhoid and HIV vaccines are there. Then there are virus-like particles which can be used, like let us be a human papilloma virus, HV virus, which can be a 40-valent vaccine or 9-valent vaccine, which is now available recently. And then we have a DNA or RNA vaccine, which we have seen in COVID-19 vaccine. So these are all about the types of vaccines. Now coming to the human normal immunoglobulins. Okay, so we have some human normal immunoglobulins which are also available for patients for hepatitis A, measles, rabies, tetanus, or mumps, where we give immediate protection by providing these normal immunoglobulins for these vaccines, for these infections. Then we have human-specific immunoglobulins for hepatitis B, varicella, and diphtheria. Then we have non-human anti-sera, like diphtheria, tetanus, gas gangrene, or botulism or rabies. Again, they're not so easily available. They're very costly. So, if there is an emergency, this immunoglobulin or anti-sera can be given. So, it is not available in the national program, but in special situations, you can make it available for the need of the patient. So, immunization effectiveness of the HIV infection, as you are aware that majority of children are born to a woman who is already infected, and therefore they do not acquire HIV infection directly. So this is a virus which is transmitted by mother to the child. So it's a vertical transmission. So many of the children may have lower immunity to begin with, and if there is more of viral load which is transmitted from mother to the baby, then there are chances that baby will have a high viral load and further immune suppression. So HIV infected children who develops immune dysfunction and affecting all aspects of the immune system with increasing age. So these are the children who requires better protection at earlier life. So these children should be vaccinated on priority basis, because if the child is severely immunosuppressed, they are more prone for various diseases and they can die early because of all these vaccine preventable diseases such as TB, which is very common, and then they can have HIV pneumonia, which is also very commonly we see. So if they are not protected with, like, pentavalent vaccine is there, the pentavalent vaccine contains 5 vaccines, but diphtheria, pertussis, tetanus, hepatitis B. So these are the 4 components are there. And of course, we are also giving the IPV, which is the fractional IPV is now given. That detail I will be sharing in the next few slides. So there are some questions comes to our mind when you are immunizing a child who is HIV infected. That will the vaccine will be effective, or is there any impairment because of the underlying immunity, because the child is having already HIV disease, and will this vaccine will alter his immunity? All the children receiving live viral vaccines or bacterial vaccines subject to a significant increased risk of the compared to the non-infected child. So that also comes to our mind, that they are infected, and compared to the other non-infected children, whether they can tolerate these vaccines very well, or they can have a disseminated disease because of the vaccination, or thus they will have more adverse events as compared to the non-infected child. So these all questions need to be sorted when you are having a doubt. When you go through all the guidelines, it has clearly said that all the vaccines are generally safe in HIV infected children. Only those children who are having significant advanced disease, who are identified clinically early, or they have a low CD4 count or high viral load to begin, and they're clinically not stable, there we can defer vaccination unless and until they are stable enough to receive that vaccines. So that also I will discuss. So immunization in a child who is having HIV. So these children having an impaired seroconversion or clinical efficacy for the vaccination, or there is a need for increased amount and or the number of doses. Like hepatitis B, it was initially we used to give the double dose of hepatitis B for HIV infected as compared to non-infected children. So these all various trials have shown that in certain cases we need to definitely give the double doses, and sometimes they also require booster doses because there is some impairment of the immunity is there. When we are injecting a vaccine to them, the children may not react to the same way as that of a normal child. So safety issues are also associated with the live vaccines when you are giving to them, because sometimes live vaccines are contraindicated with child having advanced disease. Then also there is a specific decreased duration of protective efficacy for certain vaccination. That vaccine, if it is injected, may protect for at least 5 years or 10 years. After that, the vaccine efficacy may wane off, and there the child may require a booster doses. Then what is the effect of vaccine on the rate of HIV progression? Whether it is going to halt that HIV progression or not, that is also one of the issue. So in short, if a child is HIV infected child, where mother is also HIV infected and she is immunodeficient, so mother may get infected with the vaccine preventable diseases, exposing the child to them, and there is also susceptibility of the infection for the child at an early age, and there may be a less protection of the baby from mother, because there is no hardly there are any protective antibodies from mother to the child. Then, or there is a poor transplacental acquisition of these antibodies. So the child is having a low immunity to begin with. So there is going to be increased morbidity and mortality in HIV-infected children because of these BPDs. So coming to the hepatitis B vaccines in HIV-infected children. So hepatitis B and HIV always share a common risk factors as when it comes to the mode of transmission, because many times it is a sexually transmitted disease or it is a blood product diseases. So there are chances that a child is having hepatitis B and HIV, then you have to have good care of this child, because co-infection increase the mortality in these children by 8%. So HIV-infected children are also vulnerable to reactivation of the occult hepatitis B infection, and this also progression of the hepatitis B infection to the chronicity and lower rate of loss of serum HB antigen in them. When it comes to the TB in CLHIV, as you are aware that HIV and TB go hand in hand, and there is always an increased risk of developing a TB for HIV infected child over a period of time, and it is tuned to 40 to 50%. Therefore, infection with HIV is a strong risk factor for progression from latent to the active tuberculosis. Whenever the child has low immunity, this TB bacilli is activated, and it is more severe or progressive, and mainly we see extrapolatory sites in a severely immunocompromised child. And there is also high risk of developing the drug-resistant TB in these children. And we have also seen recurrent diseases or relapses more often in severe immunocompromised child. And there is also a high mortality rate, especially the child has a low CD4 count and high viral load. So when it comes to measles, measles is very, very important, because when the child gets measles, there is sudden drop in the immunity. Why I said is sudden drop in the immunity? Because measles causes both exanthem and anthem. Exanthem is that exanthem is outside, right? It outside it causes rash. It has a particular rash starting from the behind the earlobe to the face, then to the trunk and to the body, and then lower limbs. And there is also ananthem going inside the body. What happens? This measles virus attacks all the mucous membranes, including the respiratory, GI epithelium. And you, all of you are aware that vitamin A is stored heavily in this epithelial lining. So once this measles attacks, This measles causes destroying of all the epithelial lining, and therefore these children are prone for pneumonia because respiratory epithelial cells are also damaged. So there is easy entry of these viruses, and directly they can cause pneumonia or intestinal pneumonia in these children. Then they can cause otitis media. Then coming to GID, it can cause diarrhea. So therefore, when you see a case of measles, we always give high dose of vitamin A because there is severe vitamin A deficiency there. And all of you are also aware that whenever a child is having HIV disease, we also give regular vitamin A prophylaxis for these children. So there are various studies have been conducted which has shown high mortality when there comes HIV with measles. So in less than 9 months, it is 33% HIV infected children having a mortality as compared to the 20% for non-HIV. Less than 6 months, it was 9% with HIV confirmation versus 5% in non-HIV infected. And death is also higher, which is 12.2%. So in short, whenever you get child with the measles, you have to be very aggressive in treating these children. Now coming to next infection, which is Haemophilus influenza. So we have a HIV vaccine, which is there in the pentavalent vaccine. So that can be given and it causes protection to the child. So it is one of the frequent cause of pneumonia in children, and the annual incidence is around 43.8 cases per 1 lakh, and 50 to 27% of bacterial pneumonia of non-etiology is caused by H influenza, HIV patient, and therefore HIV is having a high mortality rates in these children. Therefore, it is very important to give hepatitis, this Haemophilus influenza HIV vaccine earlier, so that it protects the child. And there is also impaired Haemophilus influenza type B transfers the antibody transmission, and therefore there is declining antibody ability through the first year of life, and which causes significant potential vulnerability of this HIV exposed child to this disease. Next is the varicella. Varicella vaccine is not available in the national program, but definitely it is available in the vaccination schedule, which is an optional vaccine and can be given. So why varicella? Because all of you are having that these children are also having a typical varicella rash sometimes, which we used to see more in the pre-ART era. But with the availability of the ART and with the better immunity, we are seeing less and less cases of varicella in children or disseminated varicella. So the complication with varicella that they can have pneumonia, hepatitis, encephalitis. We have seen lots of cases of encephalitis when pre-ART era, when the ART was not easily available. I have seen 1 or 2 cases of varicella retinitis, but more of encephalitis and pneumonia I have seen over the last 20 years. So it is better to protect if the child is having a sibling who is healthy. That healthy sibling should be given a varicella vaccine first. And if the child is also having good immunity, this varicella vaccine can be provided to the HIV infected child, so that he will also get protected. Then another important infection is pertussis. So pertussis is also having a more morbidity and mortality in children, and especially when it comes to HIV, it is more devastating to the child. So it can cause more and severe prolonged course, especially in HIV infected children. Therefore, pertussis is also available in as a pentavalent component, which is can be also separately given. Then comes to the vaccine effective and seroconversion. Then when you are giving vaccine, how much the protection the child is having? That's the question we are having in our mind. So risk of developing disease. It is not possible to evaluate the risk of developing disease in individual child because every child reacts to the vaccine differently. Some will have a good take up of the vaccine. Then coming to the efficacy of vaccine. It is said that no vaccine can provide 100% protection, though most of the vaccines do offer a high degree of protection. And almost absolutely protective is the 99%, especially measles, mumps, rubella vaccine, and diphtheria, tetanus, toxoids. Then polio, BCG, hepatitis B, and pertussis vaccine is said to be highly protective to the tune of 80 to 95%. Then typhoid, cholera vaccines, and influenza kill vaccines, they are having moderate protection up to the tune of 40 to 60%. Then concerns regarding the defective vaccine responses in terms of HIV-1 infection. So either there is a destruction and functional alteration of antigen representing cells in the body or direct affection of the HIV on the B cell lymphocytes, or there is a high level of antigen or non-specific hypergammaglobulinemia which can also alter this vaccine response in the body, or there is failure of B cell or to proliferate on stimulation that can also lead to the decreased response rate for the vaccination, or there is a defect in the generation of immunologic memory, especially indirect effect of the HIV impairment for a T cell or helper B cells, or there is a defective capacity of the B cell to differentiate in response to the CD40 or the B cell receptor triggers. Sometimes there is also clonal deletion or depletion of memory T and B cells happening in the body. This can also result in the decreased response. So when it comes to the BCG vaccination, definitely BCG vaccination is given at birth. And when you see a child who is preterm and having a weight less than 2 kg, and there we can wait till the child has more than 2 kg weight and is clinically good and stabilized. There we can give BCG vaccination. So 70% response rate is there in children born to HIV negative mothers versus 37% for the HIV infected children and 57% for the HIV exposed uninfected children. This is one of the survey which has shown. So BCG vaccination induces the immune changes in HIV exposed infants, including an increase in the proportion of the activated CCR5 plus CD4 HIV target cells. So definitely BCG vaccine should be given to all children unless the child is having a severe immunodeficiency at birth. Only there you can defer the BCG vaccination. Measles vaccination, again 25 to 30% of HIV infected children have responded to a single dose of standard titer measles vaccine in most of the prospective studies when it comes to the HIV. So 15,363 children were studied and vaccine-associated adverse events and deaths were uncommon. So HIV children had lower sero response rates after the primary vaccines compared to the HIV unexposed, which was mitigated by the antiretroviral therapy, and time interval between vaccination serology was also compared in these children. So coming to the effectiveness seroconversion rates of the hepatitis B. If there is ongoing HIV viremia, which can limit the successful vaccination. If the child has a high viral load, and then there the hepatitis B seroconversion will be affected. And all of you are aware that we give 3 doses. One is the 0 dose, that is when you give the hepatitis B first dose. Then after 1 month, that is the 1, and then after 5 months, that is 6 months. So 016 is the schedule which we follow. So 90 to 95% of the healthy individuals are protected, and only 20 to 70% of the HIV positive patients are protected. So conclusion here it is drawn that 3-dose schedule for hepatitis B is not as effective as hepatitis HIV positive compared to the HIV negative person. So a question was raised whether they can be given a double dose. So instead of 0.5 ml, give 1 ml at 016, which can cause more protection, or you can give booster doses, or whenever you are thinking, you can do their blood test and see how much is the seroconversion is made. If their seroconversion immunity is not having significant, then you can give the repeat doses or give the booster dose for the hepatitis B so that they can get protected. So persons with undetectable viral loads have higher seroconversion, which for hepatitis B, and chances of having protective antibody titers after hepatitis B vaccination was if it is a 3 double doses, as I said, if you give 1 ml, that is double the dose of the hepatitis B for the HIV positive patients, then the response was better. And it was also seen a good response when the child having a more than 200 CD4 count, which was 100% response in these patients. And whenever the child was having less than 200 cells of CD4s, CD4s in their body, the response was to the tune of 47%. Therefore, it is very, very important that child has good CD4 count, and there we can see the good seroconversion rate for hepatitis B vaccination. Now coming to pertussis vaccines. So aggregate levels were lower in HIV infected than in HIV exposed, but the uninfected children, it was 30% versus 55, and the p-value was significant 0.005. And therefore, low antibody level with severe immunodeficiency, which is especially by CD4 T cell, and it was around level was less than 25%. And there is another study from South Africa where HIV unexposed and HIV exposed infants, it was found that 3 to 4 doses of acellular pertussis containing vaccines are required, and which lower the antibody titers to the pertussis pre-vaccination have been detected in this HIV exposed compared to the HIV unexposed infants. So therefore, pertussis vaccine is also plays very important role, and if child is having a good immunity, and they can have a good sero response. Now coming to the vaccine safety and the risk of diseases for the live vaccine. Sometimes we have seen adverse drug events or adverse reaction to the vaccination. So what is the safety of these vaccines? It is said that by and large immunization is very safe and beneficial for the children. And there is also HIV-induced immune suppression, which can reduce this benefit compared to that obtained with the HIV and uninfected children. Therefore, you have to weigh the what do you call beneficiary effects. Whenever child has a good immunity, they will have a good take-up of this vaccination. Therefore, it is normally a safe and beneficial if the child is having a less immune suppression. Child has a good immunity, he will have a good take-up rate. Unless the child has rapidly progressing HIV-related diseases, usual routine vaccination should be offered according to the age. So it will be clinical directed or clinician directed. So there you have to discuss and then decide which vaccination to be given to a child at what age. So non-replicating vaccines are not associated with the increased risk of complications, and BCG, measles, oral polio or yellow fever vaccines have been reported to be associated with complications in severely depressed immunity. Therefore, when you are giving BCG or measles or oral polio, you see that child is having good immunity, then only you can give this vaccine. So BCG vaccines, it is basically immune suppression in HIV exposed babies. Usually takes several months to develop. So therefore we normally give BCG at birth only. So when you are giving BCG, just assess the child. If you think the child is not having severe immune suppression, has a good birth weight is there, and there you can give the BCG vaccination. So progressive immune suppression can also lead to the reactivation of this latent BCG. This has to be kept in mind. So poor complication of BCG vaccine can occur in certain children. Though we have seen very less complication, but we have seen mainly a BCG adenitis, which is a regional or extra regional localized or disseminated BCG disease there, which can cause regional lymphadenitis, which can, if it is severe, you can just remove that whatever adenitis is there with the help of surgical people. And sometimes they can have poorly healing ulcer and fistula post procedure. So that also you have to keep in mind. But normally BCG vaccines are safe when you give to a HIV infected children if they are not severely immunosuppressed. So live vaccines not to be used whenever a child has a CD4 percentage which is less than 15% or has a CD4 total count of less than 200. So which are these vaccines? MMR, varicella, yellow fever vaccine. These live vaccines are usually contraindicated when the child is having a lower immunity or they are immunosuppressed. So live vaccine not to be used if safer inactivated alternatives exist, and also not to be used in close contacts. So like live intranasal influenza or oral poliomyelitis. So BCG should not be used in low endemicity countries, although the risk of adenitis is substantially reduced by early initiation of the ART. So in our setup, we usually have come across less cases of BCG adenitis, and generally this BCG is taken very well in our setting. So because we are highly endemic, therefore we have to give BCG at birth. unless the child is severely immunocompromised. So what are the current guidelines for the immunization in children? So coming to that, normally at birth we give BCG, that is Bacillus calmette-guerin, along with the oral polio vaccine, 0 dose, that will be calculated 0 dose, and along with the hepatitis B bulk dose, that is also a 0 dose. Then after 6 weeks, so 6 weeks is a very crucial point where child also comes for the DBS testing and child also come for the vaccination. And also there is an opportunity for us to take the detailed anthropometry of the child. Therefore, 6 weeks very also important, because at 6 weeks we also start the CPD treatment for the child. Therefore, at 6 weeks we are going to give first dose of the oral polio, pentavalent vaccine, rotavirus vaccine, which is again oral vaccine, along with the fractional dose of the inactivated polio vaccine, first dose, and the pneumococcal conjugate vaccine, which is now recently introduced, that is PCOE1, is also given at 6 weeks. Then at 10 weeks, it is OPV2, that is oral polio vaccine, following into pentavalent 2 and the rotavirus, second dose is given. Then at after 1 month, that is at 14 weeks, we give OPV third dose, pentavalent third dose, fractional IPV is given second dose, rotavirus vaccine is third dose, and PCV second dose is given at 14 weeks. Then between 9 to 12 months, the child follows for the measles and rubella vaccine, and in certain endemic areas, JE is also given, and also we give the PCV booster dose. That is the third dose of PCV is given between 9 to 12 months. Then at 16 to 24 more months, MR2 is given, and JE2 is given in endemic areas, along with diphtheria, DPT first dose, booster dose is given, and OPV booster dose orally. Then at 5 to 6 years, second dose of booster DPT is given, and at 10 years of age, tetanus and adult diphtheria, that is capital T and small d, TD dose is given. And again at 16 years, we repeated TD dose. And in pregnant mother, we give TD1 and TD2. And if the mother has received the previously vaccinated within the 3 years, then the TD booster dose is given to the pregnant mother. So this is the vaccine schedule which is we are going to follow now. So this is what is the roadmap starting at birth. The same thing has been depicted in this picture. So now we have a human papilloma virus. So which is a vaccine which protects the child for a cervical cancer. So the country record says that there is one new case of cervical cancer is occurring every 4 months, and one that is every 7 minutes. So therefore, it is very crucial for all the pharma companies to develop vaccines. And now the vaccine has come in the markets in last 2 years. It is easily available. So in India also there are 2 HPV vaccines which were licensed in 2008. So, but now it is recommended by most of the IAP members, that is Indian Academy of Pediatrics, that this vaccine should be given to all children. So a quadrivalent vaccine is known commercially as Gardasil, which is also available. It is costing to the tune of 8,000. Another bivalent vaccine, Cervarix, is also available, which is 2,000 onwards. So both vaccines provide approximately 90% protection from the cervical cancer, with the antibodies remaining safe for at least 10 years. So in September 2022, India launches a homemade product marketed as Cervavac, so which is also a quadrivalent vaccine. So the Cervavac is a vaccine which is quadrivalent, which is having a 6, 11, 16 and 18 units that is against that virus. So the vaccine schedule is from 9 years onwards till 26 years of age. And it can be Gardasil, it is extended from 9 to 45 years, which is also again protecting for 6, 11, 16 and 18 serotypes. For Gardasil 9, which is very costly, 8,000 onwards, but it has 9 serotypes, 6, 11, 16, 18, 31, 33, 45, 52 and 58. So again, it can be given from 9 to 26 years. Both the boys and girls can be given, and 9 to 14 years, 2 doses are there. So it is usually recommended to start this vaccine between 9 to 14 years, and it has the best results for this vaccine. So what are the individual precautions which need to be followed while giving injectable vaccines? Since, as I discussed, there are some untoward events which known as adverse event following immunization. So there is a AEFI reporting is also there. So an AEFI is any untoward medical occurrence which follows during the immunization process and which does not necessarily have a causal relationship with the vaccine, or it can be with the vaccine product related reaction, or it can be vaccine quality defect related, or it is the immunization anxiety related, or it is just a coincidental event. So this all has to be reported. Suppose you give a vaccine for 6 weeks and child has high grade fever and develops a convulsions. So what is the immediate thing is there? You have to admit the child and report as AEFI, and then further investigation will take place. So there the committee records where the vaccine was given, and whenever it is HIV infected children, it is very important because you have to also see what is the CD4 count, or it is viral load if it is done, or what is the HIV staging is there for a child. So normally we give to all these children, and we usually screen whether the child is having any other illness. Suppose child is having diarrhea or fever, normally at that time defer this vaccination. Only the child having no cough, cold, or no significant fever is there, that time only we give vaccination. So therefore, when you are giving vaccine in the center, you clinically see the child, evaluate it properly, and then only you prescribe the vaccination to the child, so that we'll have a list of this AEFI. So what are the desirable vaccines not currently available to the national student? As I said, there are certain vaccines which are not easily available because they are very costly, such as inactivated hepatitis B vaccine, which costs single dose costs around 1200 to 1500 rupees, and it requires 2 doses, generally given 6 months apart between 12 to 23 months for better results. Earlier you give, better is the protection. Second is the inactivated influenza vaccine, which can be also safely given starting at 6 months of age. Again, this is given at 2 doses, 1 month apart, and 9 years above. You can give single dose, and annual booster given at this, as a single dose. Then second is the varicella vaccine, which can be administered first dose between 15 to 18 months of age, and the second dose at between 4 to 6 years. Since it is a live attendant vaccine, it is given only to asymptomatic children who are not severely immunocompromised. If child is symptomatic, then you defer this varicella vaccine because it's a live attendant vaccine and it can cause disseminated varicella in that child. A single dose of HPV is indicated if the child is not received any immunization or is unimmunized, especially more than 5 years of age. This can be given single dose. Meningococcal vaccine is also available, which can be administered between the 2 doses, at least 8 weeks apart, from 9 to 23 months of age. And a booster dose at between the 2 to 5 years of age can be given. The 3-dose series of HPV, tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis vaccine, meningococcal conjugate vaccines, all are indicated in this HIV infected adolescents. So, what are the points we should be remembering when you are giving vaccination? That HIV infant, like all other infants, should be given BCG at birth. Unless he is very well symptomatic, then that time BCG can be deferred. If BCG has not been given at birth, or for neonates with HIV infection confirmed by early viral testing, BCG vaccine should be delayed until you have started the ART and child has been stabilized and has a good CD4 percentage over 25%, then you can give this vaccine. For children who are receiving ART and have not received BCG earlier, it may be given once they are clinically well and having a good immunological stability. That is, CD4% is more than 25% for children less than 5 years of age, or CD4 count is more than 200, and if the child is more than 5 years of age. In severely immunocompromised HIV infected infants, children, adolescents, and young adults, as defined above, should not receive measles or virus containing viruses because vaccine-related pneumonia is reported because it is a live virus, live vaccine virus. So there you have to take precaution and it should not be given to them. So WHO has recommended that an additional dose of measles containing vaccine can be administered to the HIV children who are receiving ART following immune reconstitution. If they have a CD4 count between 20 to 30%, can be given additional dose of this vaccine. A supplemental dose of measles containing vaccine may be considered, especially in HIV exposed infants or soon after the diagnosis of HIV infection in children who are more than 6 months of age, who are not receiving any ART. Rotavirus vaccine, definitely it is a live vaccine, but is recommended for HIV exposed infants because we are not seeing any adverse events following this rotavirus vaccine to this HIV infected children. Because these children are more vulnerable for diarrhea, and therefore giving rotavirus will protect these children against the rotavirus diarrhea at earlier age. The vaccine virus is a highly attenuated virus, and immunization with the vaccine is given in early infancy when diagnosis of HIV infection is not confirmed most infants. Moreover, those who are not infected but not diagnosed are unlikely to have this severe immune deficiency. Therefore, it is better to protect these children where the vaccine is easily available, free of cost to the government of India across the country. Therefore, all children should be vaccinated whenever there is opportunities there. Nevertheless, like all live vaccines, it should not be given in children with known severe immune deficiency. So, in children with severe immune deficiency, definitely you have to wait and defer the vaccination further till the child is having a good immune response. Pneumococcal conjugate, that is PCV13, is again a vaccine which can be given at 2, 4, and 6 months with a booster dose between 12 to 15 months. Again, this vaccine is very, very costly. This vaccine costs around 3,500 rupees per dose. Therefore, if it is necessary, we can mobilize some CSR funds or tie up with your SACs. And if it is really needed, this vaccine can be given. Though this vaccine is very costly, but in certain children, if their requirement is there, definitely we can go ahead for this pneumococcal conjugate vaccine. It is recommended that the pneumococcal polysaccharide should be given administered at least 8 weeks after the last dose of PCV to the children with HIV infection between who are 2 years or older. So there you can give this polysaccharide vaccine after this PCV vaccine. So inactive Japanese encephalitis JE, where it is an endemic area, it is safe for the use in children with HIV infection. So our live attenuated JE vaccine is also now made available, and this is to be avoided in children with HIV, especially those who are in severe immune suppression. It is desirable to check for seroconversion and give booster doses as required, especially for hepatitis B. A 4-dose double quantity schedule for hepatitis B has been recommended because it was found that many of the children were having a poor seroconversion rates with the routine immunization. Therefore, it was a need felt that some trials showed that if we give a double dose of hepatitis B, especially 4 dose, the seroconversion rates are better for hepatitis B in HIV infected children. So, in conclusion, when you are talking of immunization in terms of HIV, definitely HIV infants and children can safely receive most of these childhood vaccines as per our national or state immunization program. And although, as I said, that efficacy may vary from child to child. Some children can have a good take-up rate of this vaccine. Some may have a very poor response, or will have a poor seroconversion rates. Some children may not have BCG lymphadenopathy, but 1 or 2 children may have BCG lymphadenopathy. Some children may have any severe adverse event with 6 first dose of the vaccination. So there you have to just report the adverse event. You have to counsel the parents, and you have to tell them that this event may occur in any child, but next vaccination also you have to take, because sometimes what happened with first dose of vaccination, if child develops any adverse event, they may not come for further vaccination. So there, a counseling and giving the medical advice is very, very important, while both counselor and the doctors So oral polio and intranasal influenza vaccines are contraindicated in HIV infected infants. So now we are having though we give oral polio vaccines, but those who are having severe immunosuppression, there I will defer oral polio vaccine. I will not give oral polio vaccine because injectable polio vaccine is available nowadays. So BCG should be given at birth, but if not given, it may be delayed in symptomatic CLHIV until the ART is started to in them and they have a good immunological response, that is good CD4 count, which is more than 15%. All live vaccines in severely immunocompromised children having a CD4 percentage less than 15% or are symptomatic at any given time should not be given. Rotavirus vaccine should be given to all HIV exposed infants due to their risk for developing diarrhea at earlier ages. Therefore, it is safe to give rotavirus, which is given as oral dose. Then inactivated Japanese encephalitis vaccine is safe for use in CLHIV and use only where it is indicated in endemic areas only. Give additional booster doses as required, especially for hepatitis B and hepatitis A, because there may be a variation of seroconversion in them. So check for the seroconversion rates and then you can give the booster doses in them. As I said earlier in case of measles, that vitamin A supplement is very, very important. So from 9 months onwards, we give every 6 monthly these vitamin A supplements till the age of 5 years. Then desirable vaccines are which are not available in a national schedule, such as inactivated hepatitis A, inactivated influenza vaccine, varicella, pneumococcal conjugate vaccine, typhoid vaccines. This can be given to these children. And immunization status should be reviewed whenever you are seeing a child in a follow-up visit, because anthrometry, immunization is very, very crucial because they are the growing child. If you don't vaccinate or if you miss any vaccine, these children are prone for vaccine related diseases and which can be easily prevented because we have a vaccine which is easily available, free of cost, and will protect them against this deadly disease. Therefore, it is very, very important to check for vaccination status whenever the child comes for your follow-up. A counselor must inform to the doctor about this vaccination schedule, and the doctor should also check the vaccination whether child is having completely immunized or not. If he is not immunized, a special effort has to be made that he received all the vaccines at appropriate time. So this is all thanks to the national immunization schedule, which is nowadays we are having almost all the vaccines which we are desiring to get it in the national schedule. Though there are some vaccines which are costlier, they are still not available. But at least those are desirable vaccines were included in the national immunization programs. So government is also taking various efforts so that all children are vaccinated, and therefore it is very important for us also, especially when we are dealing with HIV, where these children are immunocompromised from the beginning only. So it is a really challenge for us to immunize these children against these deadly vaccines which are available to us, so that these children have less morbidity and mortality. And this is my end of the talk. And if there are any questions, you can take it. We still have at least 5 minutes.
Thank you, sir, for facilitating this important session. कोणाला काही प्रश्न विचारायचे असतील तर आता अनम्यूट करता येईल. माइक ऍक्सेस देण्यात आलेला आहे.
नमस्ते सर।
हाँ नमस्ते।
सर आपने मेंशन किया है 4 डोज डबल क्वांटिटी शेड्यूल फॉर हेपेटाइटिस बी वैक्सीनेशन। सर प्लीज इसको एलैबोरेट करिए ना। What does this mean that 4 dose? We are giving 016 doses.
Yes, normally it is said that 016 is the effective, but in certain children उनको वैक्सीन हेपेटाइटिस बी मिलने के बाद भी ना सीरो कन्वर्जन होता नहीं है, पर उसको लिए आप अभी हमारा टर्शरी केयर है तो हम हमारे यहाँ पे चेक कर सकते हैं कि उसका सीरो कन्वर्जन कितना हुआ है। दैट यू हैव टू सेंड ब्लड लेवल्स। ओके, वो थोड़ा कॉस्टली है बिकॉज इट कॉस्ट अराउंड 2000 to 3000 रुपीज। अगर आप कर सकते हैं, अगर उसमें लेस देन 10 है उसका सीरो कन्वर्जन, देयर यू कैन गिव इट डबल डोज और यू कैन गिव द बूस्टर डोज एंड सी द इम्यूनिटी।
So booster dose means after the third dose, how many days after that we have to give the booster dose?
अभी डिपेंड, सपोज आपके पास अभी 5 साल का बच्चा है जिसने ऑलरेडी हेपेटाइटिस बी का शेड्यूल ले चुका है, ठीक है, उसका
Yes.
आपने ब्लड टेस्ट किया, उसका लेस देन 10 यूनिट्स आपको मिले, एंड देयर ideally you can start with a fresh dose. I can give 0, 1 and 6 double dose in this child.
Okay.
I'll go with the fresh vaccination schedule dose.
Sir, what about the adults?
Adults, I don't have much of the idea actually because I'm a pediatrician.
Actually, sir, we have received the guidelines where all HIV reactive patients need to be given hepatitis B vaccination.
Yes.
And now if a person is 50 years old and he's coming, definitely he has not been vaccinated because at that time there was no immunization schedule for hepatitis B
Yeah,
vaccination.
hepatitis B was not available. So I think it is recommended that you give 4 doses for him, 0, 1, 6, and a booster can be given after 6 months.
Okay, thank you, sir. Thank you, sir.
Any more questions? So I don't think there are any questions. Thank you so much for facilitating this session.
I think
So,
after the middle of look for this immunization schedule very in detail, because immunization which is freely available should be given, and it's a birthright for the child. We should provide immunization to them. Thank you.
thank you, sir. So we'll quickly run the feedback form. I won't keep you waiting, sir, in case you have some other commitments.
No problem.
Yeah, thank you, sir. Kiran, sir, can we run the feedback form? The feedback form is now visible on your screens. You are requested to scroll through all the 5 questions and answer them. Just click on the answer of your choice. Also, a few scenarios. Yeah, can we get the PPT in the mail? Yeah, the PPT will be sent from PCOE Sion to all the ART centers by email, along with the recorded link next week. A few centers have logged in with the name PCOE Telemedicine Sion, requesting all those centers to please right click on the login and rename yourself. In the participant list, please right click and rename yourself.
जरा सांग जरा आपल्याला.
Requesting all participants to attempt the feedback poll. Kiran sir, we can end the feedback poll. Thank you everyone for participating in today's RDLS session. The next session will be held on 6th of March from 2 p.m. to 3 p.m. and the topic is basics of chest radiology. Thank you everyone. We'll conclude the session now.
Thank you.
Thank you, sir.